So COVID-19, it has been an interesting year so far, and it has had obviously an enormous effect on our lives, but also particularly this evening on knee conditions. May you live in interesting times. I was ironically amused to read that this English expression purports to be a translation of a traditional Chinese curse, although as with most things COVID, the evidence for this claim is fairly poor. So how has the crisis affected our management of knee conditions? Well, back in March, we started preparing, as did the rest of the country, for the tsunami of critical cases that was due to arrive. All elective surgery was cancelled in all sectors, new referrals blocked. We tried to keep patients out of hospital as much as possible, so we minimized direct contact. The hospital continued to work to manage urgent cases, major trauma. We were able to deal with some very young locked knees and when there was space in amongst the other trauma. And we were advised that potential adverse outcomes would be accepted in order to save the NHS. So the second phase, May and then early into June, we realized that the first wave had been controlled. The hospitals were suddenly very quiet. The tsunami, happily, for most of us, hadn't arrived. And we started to work in teams to rebuild plans of setting up the system again. Certainly in Harrogate, and I'm sure in mid-Yorkshire and elsewhere, very hard-working teams have managed to get us started with elective day case surgery beginning last week for us, and the recovery has begun within the NHS and is starting within the private system as well. But we're faced now, June 2020, with an enormous injury backlog. Many patients haven't presented due to the fears of COVID in common with more serious conditions, cancers and heart conditions that those specialties are very concerned about. Large numbers have been held from before the outbreak and held during, who don't have definitive diagnoses and don't have a definitive management plan. There have been misdiagnoses, I'm sure, due to the clear limitations of remote working. And we've had an increased number of injuries already as the lockdown reduces, and no doubt there's a substantial more to come. So with this environment, it makes the need for accurate diagnosis critical because the delays are inevitable. For knee injuries themselves, delays can be critical in terms of the effect on the long-term outcome. Young patients with locked knees, if that diagnosis is delayed and we're unable to repair the meniscus, are going to end up with substantial osteoarthritis at a premature age. Some ligament and tendon injuries require urgent repair. I'm not talking about ACLs. ACLs can wait. This is an academy footballer, 17-year-old, who presented last week, 7 weeks after this lateral collateral ligament rupture seen over here. We would normally like to manage those within a couple of weeks of the injury for optimum outcomes. Osteochondral injuries may become irretrievable, irreparable. And so the need to get an accurate diagnosis by expert specialized consultation and imaging where possible is absolutely clear. Even for osteoarthritis, acute diagnosis, accurate diagnosis is helpful for helping that patient with plan their osteoarthritis, plan their how they're going to cope, as long as they're aware of what the delay is going to be, and optimize themselves for future treatment. So Yorkshire Knee Clinic's role, as we see it from now onwards, is to help facilitate diagnosis. We have remote consultation. I'm delighted that we now have face-to-face consultation available again, and we can arrange appropriate imaging because we've got access to that area at a time when access to imaging is heavily restricted. We are able to treat urgent cases surgically, if appropriate, whether within the NHS or the private service. And most importantly, we're able to advise the patient and their referring colleagues, whether in primary care or in therapy, how best to manage the delay that there's going to be definitive treatment, and to optimize that patient so that when the treatment time comes, the effects of the delay have been minimized. So there are some positives that can come out of this for injuries, for example, meniscal injuries, where we know conservative options are often all patients need. They can be exhausted during this delay time, so that if they're unsuccessful, the patient is already set up and ready to move to surgery if that's felt appropriate. For ligamentous injuries, the most critical advantage we have of accurate diagnosis is to be able to counsel the patient to avoid secondary injuries, the secondary lateral meniscal tear in an ACL ruptured knee that causes the devastating osteoarthritis in their 20s or 30s, as opposed to a good positive outcome. For osteoarthritis as well, it's important that comorbidities are managed, conservative options are exhausted, so that the patient doesn't have a double delay. For those patients who are significantly overweight, advice that they're going to need to lose weight for surgery is not much use to them in a year's time when they've waited a year in pain and delaying their surgery another 6 to 12 months. Finally, there is some good news for osteoarthritis in 2020. Partial knee arthroplasty is something that all the Yorkshire Knee Clinic surgeons have advocated strongly. We were very pleased to get strong support from GIRFT, getting it right first time, national team, for our approach of increasing partial versus total knees. And this month, the NICE guidelines has backed this. It recognizes the advantages. And in COVID times, to be able to reduce cost, comorbidity risk, recovery times, and hospital stay is clearly going to be an advantage as we emerge into a more normal period of arthroplasty. And the Yorkshire Knee Clinic is probably the leading clinic for partial knee surgery and research and development. So our recommendations for 2020 in terms of diagnosis was, please keep a high index of suspicion for knee injuries. Dave's going to give some more information on that. Try to ensure the patients have a clear diagnosis, and if in any doubt, refer for assessment and imaging. There will be delays to treatment. Patients need to be counseled about that, but we can minimize the effect of those delays with your help. And if in any doubt, then refer for an opinion, because the consequences of the misdiagnosis may be more significant than the original injury itself. Just to indulge me, it seems a lifetime ago, last summer we were fortunate enough to go to Namibia, which I'd recommend to anybody, and we saw this extraordinary view of a herd of zebras at a waterhole. And as we drove away, my youngest daughter turned back and saw that for some reason they'd aligned themselves. And maybe from our chaos in 2020, we'll see some order in 2021. So thank you very much. Please text any questions. I shall stop the screen share and just prepare to hand over to Dave. But John, while Dave's getting ready and unmuting himself, do you have, is there any pressing questions?
So Nick, there's no questions on the Q&A yet, but I just wanted to ask, so you raised some very interesting points, but one thing that I wonder people may not know about, How do we prioritise our cases when there's a distinct lack of capacity in the NHS? So, you know, obviously there are patients with cancer, etc. How easy is it for us to get our patients through with the severe pain from osteoarthritis, the ligament injuries, etc.? Is that something you think is going to be easy as time goes on, or?
Yes, well, I think we're not going to be competing clearly with the operating theatres where the emergency and urgent cancer work is going to be going on. And those surgeons are not able to utilise all the operating theatres once they become available. At the moment, it may seem a little bit strange, but we've started with some day case, straightforward orthopaedics off the waiting list. That's simply in order to set up the process and manage patients in a safe way, whilst the outside the hospitals in, I'm sure what John will help us understand, is a green hospital site. As the main hospital sites come online over the next few weeks, the priority will be for cancer and for similar services. But there will still be plenty of operating theatre capacity where we can deal with our more urgent major cases, and then following that start to get back to some level of normality with the general cases.
Just a couple of questions just appeared on the Q&A. So we've got a question about appointments. I think we're going to address that later on. So if that's okay, we'll keep that one on hold. And then a question about injections, which I don't think anyone's covering. So has anyone started doing injections yet? My understanding is the guidance is going to change any day now to suggest that perhaps the risk isn't quite as bad as they at first stated. I don't know if anyone's got a position on.
Yeah, I've heard the same, but there's been no official announcement as yet. So I think in the next week or two there will be an official announcement that injections are safe to continue with. So pretty soon.
Yeah, Jim, just in answer to that, there was a initial statement from BASC, the Knee Society, about 2 weeks ago, just to say you should exercise caution with both injections and NSAIDs. But I think the official BOA guidance is definitely going to come out next week, so we should know more then. But there is certainly some concern regarding adrenal suppression.
Whatever that is. Thank you very much, John. So, right, if I hand over to Dave Duffy to talk about knee injuries. Thank you.
So, good evening. You can hear me, Nick? Is that all?
Yes.
And you can see my screen. So, thank you for joining us this evening. I'm going to give a short presentation about injury recognition, because probably like me, we're operating in very strange times and being asked to conduct clinics or consultations virtually or by telephone. And I feel slightly exposed that you're being required to make decisions with incomplete information. So the purpose of this talk is just to give you some signs and some pointers as to what to look out for, particularly with an acute knee injury. Now, the delegate list is quite broad and varied, so the topic of the presentation hopefully will cover a number of issues for everybody. Just as an advance warning, there is some surgical video content, but nothing that is too graphic. So when it comes to an acute knee injury, if you're going to simplify it or strip it down, I think there are two very important and essential questions you need to ask of any patient who's had a knee injury. And the first is, were you able to continue playing the sport? If the answer to that is yes, then my index of suspicion of a serious injury goes down. So if they were not able to continue playing sports and had to leave the field, the next question is, did the knee swell? And again, if the answer to that is yes, you immediately follow that up with a question of how quickly, because this is where the crux of it lies. Because if it's rapid swelling within an hour, it is a hemarthrosis. So something has bled into the knee, and that is the sign of a significant injury. Now, if the swelling is delayed, maybe 24 hours, it's more likely to be reactionary and synovial fluid. So rapid swelling within an hour and an inability to continue with the sports is a significant or serious injury until proven otherwise. And really, there are only four major injuries, or four major groups of injuries, that would cover over 95% of this presentation. And we'll go through these in general. And the first is a major ligament injury. The second is a patella dislocation. The third is a large peripheral meniscal tear, so where the blood supply is. And the fourth is a fracture. So when you come to a ligament injury, one of the most common ones we see are ACL ruptures. And we're seeing these increase in frequency, both as participation in sports goes up and equally as the general population and healthcare providers become more proficient at recognising the injury. But it's often sports that involve a sidestep or a turn like football or rugby. You can also get them in netball and basketball when landing onto a single leg, and skiing. Paradoxically, the lower velocity injuries when the ski binding doesn't come free. And the mechanism for sports, 2/3 are non-contact. And I think this is initially over the last 20 years has lulled people into a false sense of security. When patients are presented to emergency departments with a non-contact injury, the severity or the perception of the severity has been reduced, but 2/3 of ACLs are non-contact. This is one of the most famous caught on camera, and it was from 2006. And it's Michael Owen, and it's his right leg. As he kicks the ball, he plants his foot, and then the knee jumps. Now, there was nobody within 20 to 25 yards of him. He was unable to continue playing, rapid swelling of the joint, and he'd ruptured his ACL. So with an acute injury for an ACL, the history is 90% predictive. The patients often describe a sensation of the knee dislocated. They can often feel a pop within the knee. Almost all are unable to continue playing, and the majority describe rapid swelling of the joint. And in that the first day or the first 1 to 2 weeks, they are difficult to examine. The patient does not like you examining the knee. With chronic injuries, again, most of them are diagnosed on the history alone. They had acute swelling and pain. It's not unusual that they presented to an emergency department. An x-ray was taken, which to the treating physician was unfortunately they perceived as reassuringly normal, and they were diagnosed with a knee sprain. And if it's an isolated ligament injury, it is unlikely to cause ongoing pain. So the symptoms of pain and swelling can settle after a few weeks. And unfortunately, these patients then return to their sports and sustain a secondary injury. So this video is, just to get you orientated, we're looking in the center of the knee at a normal ACL. And basically, when I look at a normal ACL, I look for three things. I look for the tension of the ligament. I look for its attachment points to the femur up at the top here, and its attachment point to the tibia, and also the volume or the size of the ligament. On an MRI, you look, it's this black line running from the tibia to the femur. Now, when it ruptures, it tends to pull away from the femur, and here's an acute rupture with what we call a cyclops lesion, with the remnant of the ACL caught in the center of the notch. And this can often limit movement, particularly extension in the early stages. In a more chronic picture, here you can see that the actual volume of tissue is diminished, but most importantly, there is no attachment point to the femur that can be seen on the left. Partial injuries are difficult to diagnose because on a scan, you can tell the ligament has been injured, but you can't necessarily work out how much. And whilst that scan appeared normal, when examined arthroscopically, the actual number of fibers attaching to the femur was significantly reduced. So the gold standard for an ACL surgical treatment, that is a reconstruction. And here's just the basic principles where the old torn ligament is removed to create space for a new graft. The attachment point on the femur is identified, and then a pilot hole is made with an awl. And then using drills of specific diameter, this is gradually increased to make a socket into which your new ligament will insert. A similar technique is used on the tibia, and then the ligament is pulled across the knee. And in this case, hamstring tendons have been used to make the graft. Here is the final ligament, crossing the knee, attaching to the femur, and it can be compared to what a normal natural ligament looks like. So the second is patella dislocation. Again, rapid swelling, inability to continue with sport. And this may be confused with the story as presenting very similar to an ACL injury. An X-ray is essential on the acute presentation to look for an osteochondral injury. And in my own practice, if it's a first-time event, I'd like an MRI within 2 weeks. And the reason for that is to look for a reversible pathology. On the screen here, this is an MRI, and just to get the orientation, the patella is at the top here, and this is the femur. And on this scan, the bone should be dark as it is in this area. But what you can see highlighted with the red circles are two areas where the bone is significantly lighter or white. And this is bone edema. And at the time of the dislocation, the patella has come out and hit into the femur before relocating. Now, the size of that force can knock off bone or cartilage fragments. And on this scan here, another MRI, the yellow arrows point to a piece of bone and cartilage that have been knocked away from the underside of the patella. Now, if this is diagnosed early enough, then potentially it is repairable. However, if it's diagnosed late or doesn't present late, these loose fragments can get caught within the knee and get stuck down, as this one has. It's again in the center of the knee. It's now tethered to the soft tissues and it's in front of the ACL. Now, this is not suitable for any repair, but would cause mechanical symptoms, so it just needs to be removed from the knee. In the next example, we're looking into the suprapatellar pouch, where a piece of chondral surface or cartilage again has been knocked off the underside of the patella following a dislocation. This has no bone on the undersurface, so wouldn't be suitable for a repair, so would just need to be removed to reduce any mechanical symptoms of this fragment floating around the knee joint. The third are meniscal tears, but very large meniscal tears. The meniscus has a poor blood supply, and the blood supply is right at the periphery where it attaches to the capsule. As you move further into the knee joint, we get into an area what we call the white zone, where there is no blood supply. So a tear in this region will not bleed. It wouldn't normally cause rapid swelling of the joint, but equally, it's less likely to heal. So on this video here, again, we're looking into the medial compartment of the knee, a normal knee. So we've got the articular cartilage on the femur, there on the tibia. And between the two is this semicircular structure called the meniscus. Now, the reason all these structures are white is they have a very, very poor blood supply, except at the periphery where the meniscus attaches to the capsule. In this example, we've got a flat tear of the meniscus. Now, that's not going to heal and it's not suitable for repair, so it is removed to reduce the mechanical symptoms. It is removed using an arthroscopic punch and a shaver to remove the debris. And the aim of the procedure here is to essentially stabilize the meniscus and to remove any unstable tissue to get you back to a knee joint without mechanical symptoms. But what you can appreciate from the surgery is there's absolutely no blood within the knee, because at this area of the meniscus it's avascular and it's only at its periphery where it's got a vascular supply. And the final cause of rapid swelling in the knee joint is a fracture. Now, on this plain X-ray, it's not possible to see any break in the bone or the cortex, but what the arrow is pointing to is a phenomenon called the lipohemarthrosis, where this straight line is an interface between fat and blood. And the reason fat is now within the knee joint is it's come from the marrow because there's been a breach in the cortex. So if this is seen on an X-ray, it's pathognomonic of a fracture somewhere within the knee joint. And if not immediately visible, further image is required. Now, let me just get. So on this video, this is an acute fracture at the base of the ACL. And the first thing to notice is that the image is murkier than the ones you've seen before. The ACL ligament is there and that's perfectly intact. But at the base, there's a rather large fracture and that has lifted up. And this would cause rapid bleeding into the knee. And once it's been cleaned, you can clearly see this plane where the bone is basically lifted up like a trapdoor. And the structure that the probe's examining now is the intrameniscal ligament that can get caught under this fractured piece of bone. On the CT scan, it can clearly be seen here where the fracture is, and it's lifted off its bony base. And on an MRI scan, you can appreciate that the actual ligament is intact, but there's a large fracture that is lifted off. Now, if this is not identified or diagnosed within sort of a 2-week window, it makes repairing this more difficult. And in this case, it was repaired with 2 threaded screws. So in summary, and the take-home message I would say is that acute knee injuries are common, and the diagnosis is normally on the history alone. It's about 90% predictive. And the 2 most sensitive questions I would ask or teach juniors to ask to decide whether this needs an urgent referral is an inability to resume sports and rapid swelling of the joint, because rapid swelling means something's bled, and there are 4 main causes of bleeding in the knee. Thank you.
Thank you, Dave. That's very good. We're going to be switching over to John Smith, the other John Smith, with the ladder behind him. Just a question, Dave. Should all suspected patellofemoral dislocations be referred for urgent MRI?
In my opinion, first time should be, because the first time is normally is when the most significant force has been applied to the knee, and it's the time when you're most likely to have acute swelling and a possibility of an osteochondral injury associated with it. The recurrent patella dislocations, it's less likely and probably impractical to keep referring those for an MRI within 2 weeks. But first-time dislocators, if feasible and and the circumstances allow, I would normally want to get an MR within 2 weeks.
Okay, thank you very much. There's a good question just come in that we'll take at the end about ACL repair. But John Smith, over to you, please.
Great, thanks, Nick. And it's a real pleasure to be talking to you all tonight, and really looking forward to it. So I think when I got to the start of this year, I thought 2020 has got a nice ring about it, but I think we've all just got off to a bit of a false start, really. So I just wanted to do an update on where we are now and how we're going to proceed. As a surgeon, you're always taught to first do no harm. So I think the most important thing to consider at the moment is to proceed with caution. The graph you see there is the Spanish flu with that second peak, and we've already seen that in some places in the UK, with the Somerset Hospital recently closing its doors. And you know, when you look at this, you've really got to act with caution to protect sort of patient and staff safety. Worryingly, there's also a couple of papers that have been published within the last 2 to 3 weeks in the Lancet. The first one is a large multi-centre trial involving 235 hospitals in 24 different countries, looking at patients with perioperative COVID. And 75% of those were emergency cases, but 25% were elective. And the pulmonary complications were extremely high, up to 50% in those cases. And of those, they were associated with 40% mortality in those cases, which is obviously severe. They did note that the at-risk category was certainly males over the age of 70. And the summary was that our threshold for surgery should be much higher at the moment than is normal practice. Now, the second paper that you can see just at the bottom of the screen there is the now famous paper from Wuhan, and this was published in mid-April, and this involved 34 elective cases, of which 40% were admitted to ICU and 20% were associated with mortality. So this is why we need to be very cautious when resuming elective surgery. What's going on in the UK? Well, we've all seen this in the newspapers this week. Apparently there was 540,000 patients waiting for a cancer operation. And that goes along with significant problems with shortage of anaesthetic drugs and personal protective equipment. And we also need to repatriate our anaesthetists, our anaesthetic colleagues, and indeed even the anaesthetic machine. And as Nick mentioned earlier on, that coincides with a real upsurge in our trauma workload as lockdown is released. And all of this is putting huge pressure on the elective service. I attended a BOA webinar a couple of weeks ago, and the steering committee even suggested it may be October, November before we see return of elective services as we know it. Again, this is a headline from this week, and most of you will know that the NHS has got a national contract with the private hospitals, and that was up to June the 28th, but that's already been extended until the end of August. And certainly with 10 million patients potentially on the waiting list by Christmas, it's very likely that those private facilities will be used in some way over the next 6 to 12 months, if not further ahead. In terms of where are we going to be doing these operations, Nick touched on it earlier with regards to the gold, silver and bronze hospitals, and I'm going to talk about that later. But we need to consider regional variations with this graph you can see here on the right of the screen. And also looking at each trust, their individual setups is different. For example, Mid Yorkshire, we have a hot site at Pinderfields and then 2 cold sites at Pontefract and Dewsbury, so that may lend itself to starting elective services sooner rather than if it was a single site, which many trusts are. And indeed, some elective services have started up and down the country. In Ipswich, they've already done 115 cases during this pandemic, and they've only got 1 post-operative COVID patient, which presented at 2 weeks, which is promising. And also down at Stanmore in Middlesex, they've done nearly 200 cases, and so far so good, no cases. So this reintroduction of elective services may well be on a regional basis, but I don't think we know yet. Now, this slide is from the BOA website, and what we're aiming for is a golden hospital, which is essentially a separate site with separate facilities, with no A&E, which is a clean area. And locally, with the Yorkshire Knee Clinic surgeons, we've already started working out of Spire Methley Park and also the BMI Harrogate Duchy, because these are sites which are essentially golden with no A&E and no medical patients on board with COVID. And that's really what we're looking to start. And also with social distancing to consider, it would be nice if those golden hospitals have also got separate side rooms, as which many private hospitals do, because there are implications with an open ward. Diagnostics are going to be extremely important for 2 reasons. One, picking up the acute knee injuries as Dave has described with the early diagnosis, but most importantly, looking after the huge backlog in cases, and certainly at our trust, there was an enormous number of MRI request forms that went in pre-COVID that have then been just put on hold. So it's going to be massive pressures. And it may be that we can use some of these Nightingale facilities, such as the one in Harrogate, to perform some of our radiology and down at the Leeds Nuffield as well. Now, the first step really is in deciding who to operate on is to review your own waiting list. And that's certainly something that we've all done at the Trust. Now, there may be a number of outcomes following this. The patient may just want to carry on, they may want to postpone, or they may want to withdraw from surgery altogether. And in certain centres up and down the country, they've actually looked at this, and up to 20% of patients currently on the elective waiting list no longer wish to have surgery, which is obviously a concern. And it just goes to show what impact this has had on patient choice and perception. But just to put it into perspective, on my waiting list when I was looking at mine last week on the NHS, I've got 50 ACL reconstructions waiting and close to 100 joint replacements. We also need to prioritise the operations, and we're in direct competition with finance with all the other surgical specialties. And this is the way that I've just broken down some common knee problems. So a 1A or a 1B would be an acute injury, perhaps an open fracture or a patella tendon injury or quadriceps injury. a lock knee would come into a P2 to be operated on within 4 weeks. But the bread and butter of our work, the ACL reconstructions of the routine arthroplasty, have been banded as a priority 3 and 4, which is of some concern. And this is a paper that was published by Chloe Scott in the JBJS last summer, and they looked at 4,000 patients waiting for a joint replacement, 2,000 hips and 2,000 knees. And they found that 20% of patients waiting for hip and almost the same waiting for a knee were in a Euroqual 5D health state worse than death. So we know that waiting on waiting lists is very detrimental to health and quality of life, and that's something really we need to consider. This again is taken from the BOA website, and this is looking at routine arthroplasty. This may be a way we can try and expedite some of our joint replacements, because if the patients do have severe pain, reduced mobility, really bad preoperative Oxford scores, and progressive deformity, then we can potentially expedite these from a P4 to a P3. And I think we really need to be looking at that as a loophole to get these patients operated on. Now, the other thing to consider, as well as the procedure, is the risk. And this is a good paper from the British Medical Journal just published last week. And this is a multi-centre paper looking at 20,000 inpatients with COVID, and looking at risk factors, clinical risk factors. And again, males over the age of 70 was very characteristic. But what they did, they drew these conclusions, and they were able to stratify the risk according to age and risk factor. It's quite clear that chronic cardiac disease and diabetes, as well as COPD, are key factors. But we're now able to stratify these patients according to the medical risk, as well as the procedure that they might be having, and this is going to be quite useful for us. As Nick already touched on, I was very pleased to see this published last week. And for the first time offering patients both partial and total knee replacement for medial compartment arthritis. And this is certainly one way that we can reduce risk, because we know that uni knees are associated with much lower morbidity in terms of surgery, a faster recovery, and even a potential to do them as day case, which we often do. And this is certainly something that we're advocates of at the Yorkshire Knee Clinic, to try and reduce risk. Now, an ideal scenario now is a green pathway in a golden hospital. And this is quite a complex slide, and I apologise for that. But one key thing to pick out is the fact that the elective patients now are advised to self-isolate for 14 days pre-operatively and post-operatively, which is a really big commitment. That can involve either self-shielding at home, or indeed the whole family self-isolating, and it's difficult. And I think this is going to be a real stumbling block and a real difficult thing for us to get our heads around. But this is known as a green pathway. A blue pathway would be any pathway where the COVID status of a patient is not clear. But this is the standard that we want to set. And we can just summarise that in terms of the prehabilitation of the patient, a rigorous pre-op assessment, the isolation I've mentioned, and then pre-operative swabbing for COVID, usually at 72 hours before surgery, and then screening them all on admission. And what we're aiming to do is reduce the risk of patient to staff infection, staff to patient infection, etc., as shown in the bubble there. And there are big questions nationally at the moment regarding testing of any medical staff in the hospital, nursing staff. But in some units, between 10 and 30% of the staff have tested positive for antibody. And there's new government guidance coming out on the track and trace policy, which is also going to have big impacts on the healthcare system, because some members of staff may actually be sent home, which could have a problem on the workforce, should you have been found to be in contact with a patient with COVID. So the track and trace is going to have an impact as well. Now, online at the moment, there are some excellent documents that we can use to support our patients preoperatively. And these are a couple that I would recommend you having a look at. One is the Centre for Perioperative Care, and one is the Royal College of Surgeons guidance. And these are very patient-friendly guides to try and help patients out, because one of the problems that I think we will see is that many patients will have been really deconditioned during the lockdown, and apart from nipping out on a Thursday evening to clap the NHS, many patients may have become very sedentary and unfit. And this is the type of advice that we need to be giving the patients pre-op to really try and optimise them and get good outcomes. The other key thing to mention regarding surgeries is consent, and this is very, very difficult. This is a good paper that I read recently on consent, and this is some WHO guidance. But the problem is that we don't really know how to quantify the risk in terms of COVID infection or indeed death. There's an issue about liability, and there's also issues regarding, are we going to be able to offer optimal treatment, because many of these patients are going to present to us late. I think the surgical time will be higher with PPE, and with longer surgery time you can get increased infection, and also increased length of stay as well. And all of these things need to be borne in mind when you're consenting patients for surgery in a potential suboptimal environment. It's very likely we're going to need pre-printed specific consent forms for the pandemic era, and also dedicated virtual consent clinics when you can go through things with a fine tooth comb with the patients. But it's a real minefield. In terms of theatre and what's happening, there's a lot of debate about the type of anaesthetic that patients should be getting, and whether or not a spinal anaesthetic is safer than intubation with a general anaesthetic, although recent evidence suggests that both are equivalent. Distribution of theatre staff, so having less patient inside the operating theatre and more support staff outside. And then there's a whole host of debates going on regarding what equipment we should be wearing and when. And something called AGP, which is aerosol generating procedures, which potentially, if you're using a high-speed drill, or you're drilling bone marrow, for instance, with a knee replacement, then would the viral load within the bone marrow or the blood be a potential contaminant? There's a whole area of debate here at the moment. But from my perspective, I've certainly noticed a difference in morale within the theatre team with people wearing PPE. Communication can be a problem, it's uncomfortable. And on top of that, you're certainly going to slow the list down, and there's going to be 50% less throughput. We've also seen quite a bit of dual consultant operating, as potentially some surgeons are getting de-skilled with the reduction in the numbers, and that's a good safety net. So I think with the PPE, it's a case of watch this space, and we're awaiting further guidance. Now, in terms of discharge and follow-up, as Nick mentioned earlier on, we're starting off with some simple cases and routine day case arthroscopy and ACL, potentially uni knees, and that's the safest thing. We really need to be looking at enhanced recovery and remote follow, which Jim's going to talk about next, and using things like the My Mobility app from Zimmer Biomet, so that patients can actually collect their own data and send you photographs of the post-operative wound, etc. And this is the way forward, and this is potentially something good that is going to come out of this crisis. So just to summarise, I think the main impacts of COVID-19 for us in knees are going to be really poor theatre efficiency, which is going to have a knock-on effect with the waiting list. Certainly some training issues in terms of elective numbers. But for me, and what I'm seeing already, is this problem with patient perception and how we're going to regain the patient's confidence and the public confidence, addressing the patient's anxiety and mental health to try and make sure that those numbers refusing elective surgery are not increasing, and also to try and minimise these delays in surgery which can be associated with poor outcomes. And I think they're going to be our two biggest battles. But just try and finish on a positive note. I think whenever there's change, there's certainly opportunity. And I think we've got to now move forwards and really sort of reflect on what we've done previously and try and improve pathways and streamline care. And I think there is something that good that can come out of this. So thank you for your attention. I'll hand the baton over to Jim.
Thank you, John. Just while Jim's getting himself ready and screen sharing and unmuting himself and things, would you, there's a question from Charlotte Pedley. Will there be consideration into the post-op rehab provision for acute knee injuries and the number of operations being undertaken? Obviously, physiotherapists have the same problem that everybody's having with having to adhere to distancing, and facilities aren't really geared up yet, so capacity is reduced. So I think the concern is that we're starting with surgery and going to start sending numbers through that can't be coped with.
Yeah, I think that's a hi Charlotte. I think that's a really good question. I mean, certainly, you know, the trust at the moment, the physiotherapists have done a fantastic job with virtual clinics and virtual advice by video consultation or phone. But that is something to consider in terms of the numbers. That it might be that initially we need to do a mixture of both face-to-face and non-face-to-face support to allow capacity, but we need to start phasing in those normal pathways again as we did before.
Thank you. So over to you, Jim.
Right, good evening everyone. Thank you very much for joining us all on our first ever webinar. So far technically it seems to be working okay. So my name's Jim Newman, I'm a consultant knee surgeon, and I'm going to be talking about how COVID-19 has really affected the way in which we do routine day-to-day stuff within orthopedics. So I hadn't realised that John had put 2 cheesy quotes in his talk, so here's another one. But it is fair to say that when you're in an adverse situation, it does force you to change, and you do learn things from it. And you know, be in no doubt that the situation of coronavirus COVID-19 was a fairly harrowing experience for a lot of people, and we have been forced to change. So what is the new normal? What does the new normal look like for us? So it's forced us to change, and some of the things that we've learned to do actually are better. And what I think is very, very important is as the numbers decrease, what we don't want to do is go back to what we did before, particularly if what we did was a positive change. We don't want to take a retrograde step. It's also important to remember that the outbreak has yet to end, and we may well see a second peak, particularly over winter. So anything that worked very well now, we should carry that on just in case there is a second peak. And the main thing I'm going to be talking about is how our outpatient management has changed, and I think will probably continue on. So what are the prime goals of changing our outpatient pathways? Very simply, we have tried to reduce attendance. Ultimately, if a patient comes into hospital, either the staff are at risk of being exposed from coronavirus from the patient, or vice versa. So that's the main goal. And the secondary goal of doing that, of course, if you can reduce the number of attendances, patients are not having to travel from place to place. They're not having to find a parking spot, pay the absolutely ridiculous parking fees that we often see in these hospitals. And then the other thing, we often see a lot of attendances to hospital which actually probably didn't need to happen. And so reducing wasted attendances is a really good goal. So there has been a rise in non-face-to-face consultation. And when you say non-face-to-face, it's exactly what it means. You're not coming in to see a consultant. It's either a consultation over the telephone or perhaps better over a video consultation. Now, it's fair to say in orthopedics, this is not a new thing. So virtual fracture clinic has been developed since a lot of trust for several years now. And more recently, we've developed a virtual arthroplasty follow-up, so it's a joint replacement follow-up, all done remotely, all done over the telephone. And generally speaking, these services are really, really good. The real question is, though, can you have a service like this and do it for new patients? Similarly, what about patients that you've already operated on? So the big question is, why haven't we done this before? Well, I think the main reason we haven't done it before is that when you think about your traditional assessment of a patient, it consists of 3 main things. The first being the history, the second being the physical examination, and then the investigations that follow. And the history is absolutely key to a diagnosis. And the thing you'll see on the right hand side of your screen is an excerpt from a dusty medical student book I found in my basement. And it is fair to say that at least 80% of the diagnosis is made from the history. It's probably fair to say as well, if you see an experienced subspecialty clinician, surgeon, who's had a very, very large volume in dealing with these patients, that can potentially go up. Now, when you see a patient, you always like to examine them because you get a lot out of that. But the question is, do you need to do that on the first attendance? And with newer modern investigations such as detailed MRI scanning, we can get a lot of information from the investigation, which can sometimes take the place of the examination. Also, the other thing that stopped us doing this in the past is the perception that the technology isn't there. And actually, all these Microsoft Teams, Zoom, they've been there for a long, long time, but it's probably the fact that none of us, up until recently, have been au fait with using this technology. And certainly, it's fair to say, we never would have contemplated having a webinar this time last year. But because we're using these formats now, we're much more confident. And that goes for patients as well. Then the next question is about technology with older populations. So there's always the worry that your more elderly patients will not be able to access these things. Now this is from the Office of National Statistics, and if you look at this one here particularly, what you can see is that the growth of internet use amongst our more elderly population is going up significantly, and that's the same with use of smartphones, etc. Now what we've found is obviously if your more elderly patient does not have access to this thing, we would always see them in a face-to-face fashion. That goes without saying. But I've had a number of slightly comical Zoom consultations where a more elderly patient is managed to get their laptop or iPad going, and there's been problems, and you've seen a hand come in pressing buttons, which is clearly a friend or a relative who perhaps shouldn't be in there due to social distancing. And then the other thing to mention is GDPR. So clearly any information it should not be shared, and that has always been a worry. But most of these platforms now have end-to-end encryption, and certainly Zoom has been adopted by the Spire group. There's an encrypted version of that, which is what we're using from the Spire hospitals. So just to sort of try and understand why this is better, I will look through what a traditional outpatient referral pathway looks like and what it can look like with non-face-to-face video consultations. So you have to bear with me a little bit with this. So first thing I want to point out is that if there's a red arrow, that would represent a physical journey, someone getting in the car, bus, taxi, or whatever. So in this scenario, what we've got is a patient that's been referred to one of us, and they've had a full workup. So perhaps they've seen a physio or a GP, they've had appropriate investigations, MRI. Now, a traditional pathway would mean that they would drive to the hospital, we would see them, examine them, and then we would come to a diagnosis because we'd already have the diagnostics and decide whether we wanted to list them for surgery, or perhaps if it wasn't the right thing for them, send them off to physiotherapy. So in these patients, they would have a very small number of journeys. I suppose the question is, why would you see these patients non-face-to-face? Well, so recent experience has shown that even in these patients, doing a video consultation can be useful. So same patient, we've got all the information required, but actually if you do a virtual consultation, so there's no physical journey, they're talking to us over a video, the diagnostics are available. At this point, without examining them, you can have a very, very good idea of what the likely diagnosis is and what the treatment will be. Now, I have had experience here when, having spoken through about the potential for surgery or non-operative management, the patients decided that at this point in time they don't want to have surgery and they'd like to go down the route of physio, etc. Now that means that patient has not had to come in to see me to make that decision. They can go to physio, and there's always the opportunity for them to come back at a later date. Similarly, if we both decide that actually they would be a reasonable candidate for surgery, it makes absolute sense at that point, though, for them to come in and see us, because it's vitally important that if you're going to list someone for surgery, that you meet them face to face, you have the opportunity to examine them, and then you can go through the consent process. So even in patients that have been fully worked up, I would say a non-face-to-face video consultation is very useful. But where it's really, really useful is patients where there is very little information that comes with a patient. So often this might be a self-refer patient. So they may come to you, there may be no investigations, no past history from the GP, etc., etc. And what would normally happen, they drive to the hospital, you'd see them, you'd take the history, you examine them. You may then need some diagnostics and MRI scans. They drive to the MRI scan a week or two later. Then they drive back to the hospital for their results. And then if you decide surgery is not for them and maybe they need some physiotherapy, another journey. So you can see that is a lot of physical journeys for that patient. Whereas if we look at what happens if you use a non-face-to-face, so you see them, you take your detailed history, and as we've mentioned from that most likely thing, you usually have got a very good idea of what the diagnosis is. You can then send them for some diagnostics. Once that's done, well, you don't need to bring them back for the results of their diagnostics. You can do a non-face-to-face. And then similarly, if you decide that, that they're likely for surgery, I would always bring them in. If you decide that between yourselves that perhaps surgery is not for them, then you've got the opportunity to send them across. And you can see that this significantly reduces the number of journeys for that patient. And really, in order to make that experience for the patient far better, this is a very, very good opportunity and option. So video consultations, I would say, can reduce the physical journeys for as much as 2 trips. However, there is always a concern about the lack of physical examination. That's absolutely right. So for myself, if I'm going to list someone for surgery, I would always bring them in for a face-to-face. I'd always want the opportunity to examine them, meet them, and discuss consent. There's always a situation where you take a history, you get the investigation, and the investigation does not match what you think the history is. So a really good example of this is a patient that swears blind, their knee's hurting them. You send them for some plain x-rays of their knee and it's normal. Chances are they've got hip arthritis that's been referred, and that would not be picked up unless you examine that patient. So those ones, again, you would bring back. Again, funny, atypical presentations, red flags, worrying signs, features, you would always bring those patients in. And then I would say for acute ligament injuries in particular, it's quite important to examine the limb there, because whilst the investigations are really, really good, I think Nick mentioned it, it might have been Dave earlier, about partial ACL tears. You can gain an awful lot from examining that knee that the MRI scan won't tell you, because an ACL tear is a dynamic injury. So if you were to perform a pivot shift test, for example. And then the other thing we often see is posterolateral corner injuries. They tend not to be that well diagnosed on MR scans, and examination is a lot better. So all in, I think you can improve the patient journey by using non-face-to-face physio consultations, but you do have to do things differently. And my experience of video consultations, well, patients love it. They absolutely love it. I've not had a single patient that didn't have anything to say but good things about it. And I would say it's like a turbocharged triage service. So you're ensuring your patients have got the correct investigations so that if they do come to see you, everything's there. It's not uncommon for you to be able to advise, reassure, and discharge. And then the other thing is, if I'm thinking about offering a patient surgery, I can talk to them about the risk there, and that gives them a period of time to have a think about things before they then come back see me in the clinic, and then we can discuss that there. And even the most venerable elderly gentleman can work it, and I can say that because that's my dad, not a patient. So what's the next steps? So there's some really exciting technology coming out, and John mentioned this. So these are patient pathway apps or patient journey apps, and the way in which they work is that they offer a integrated way to communicate with your patient with all the other different departments in your hospital. So the waiting list office, physiotherapy, the ward, all these sorts of things. They're really, really clever. So for example, if I put a patient on the list for a partial knee replacement, what will happen is they'd download the app. The app would then sync with the central waiting list, and they would know that the app knows when they're due to come in for surgery. It sends push notifications. So, for example, here you can see on the Apple Watch here, you know, what to bring in hospital. It would tell them when they should be attending for their pre-op, etc. It really is very clever. Once surgery is done, you then have the app which you can alter depending on your particular physio regime. So the physios can help write what particular regimes they want, and also it will monitor it. So a lot of these things, the Apple Watch, the phone, for example, they've got accelerometers in them, and they will track steps and all these sorts of things. And what's really smart is then on the clinician end, so the bit that I can see, the physio, the wardness, etc. There are all these measurements that we can tap into. So, for example, up here, you can click on progress, and it will look at where they're progressing in their standard physio and rehab. In terms of keeping an eye on how well we are doing as a team, as a department, you can send pain scores and PROMs out to the patient. Again, push notifications, ask them to fill that out. If the patient has any concerns, they can always use the messaging thing. So all in, I think these types of technology will take us through to the next stage, and I'm fairly excited about a lot of this thing. I think it will offer us a lot of things that we couldn't do before. So how do you refer in? So to be perfectly honest, the actual method by which you refer in hasn't really changed. It will be the way in which we decide we want to see the patients different. So standard, you know, general practitioner letter, physiotherapy letter, self-referral. You can go to the website, for example. The private providers, so this will be AXA, Bupa, the usual ones, are very, very supportive of the video consultations. I think they have seen this for some time, that this is a real win for their customers, and our patients, and I would be inclined to agree with that. Just to sort of make it clear that I'm the clinical director for our department, the restart date for NHS referrals has yet to be decided, and we know that we're sitting on a mountain of referrals. The waiting lists as they stand are astronomical, and quite how we're going to get over this, I really don't know, and it's quite a daunting task. But I think over the next 4 to 6 weeks is when we may see new referrals begin to come in, and I think obviously very much depends on how the coronavirus, the COVID-19 situation looks in terms of numbers. So in summary, COVID-19, it's made us look at the way in which we work and all the normal things we do, and it's been good to be challenged, because I think we're beginning to change and move with the times a bit and offer new technology and different ways of working. The new tech that's out there can certainly help us, and I think it's important that we start to look at using that. I think the next step is maybe to get some of the hospitals to invest in these apps. They're currently they're currently quite cheap to install, because I think a lot of the companies that make them are really keen to help and get these things in. Whether they'll stay like that, I don't know, but it's certainly an opportunity for us. And then if we've got all this stuff in place for winter, which I think is a real worrying time in terms of either another peak for coronavirus or even the pandemic flu, having all this stuff in place will help us continue treating patients without having to shut everything down, in which we did this time around, because it completely caught us on the hop. I'll happily take any questions if there are any.
Yeah, thanks, Jim. I've got a question for you just in a second. Before people start drifting away, we'll run the questions for a few more minutes. We are a little bit over time, but if people are interested to hear. A question is, are we going to have the presentations available? Yes, the whole evening is going to be sent out as a connection from the cloud for people to watch again if they'd like to do that. And I have just written a poll just to see if this works. So we'll launch that. So if people can have just a look at that and answer them when you can, it'll just help us, because we are planning future webinars, and you might save us a lot of time and effort if you were brutally honest and answered number 3 or number 4. Jim, we have far greater experts in the audience on live remote consultation, in that our primary care colleagues have been doing this for some time, but particularly obviously during the COVID period, are doing it with a majority of their cases. Nicola raised, and I agree to an extent, I fear what we're missing. And Nicola's sent a second question, and it takes much more time to safely consult over phone and video, and we miss the visual cues you get with face-to-face. What do you feel about that?
Yeah, so I think that is where sending patients to people who are very, very au fait with dealing with the problems is important, because that is our area of expertise, I guess, and I still think you can pick up a lot of these cues. Ultimately, you always have that fallback of a face-to-face if you're not really sure what's going on. There's something doesn't quite match, and that comes with experience. So for me, I think there's always a risk with any way you manage a patient, but I've been very, very surprised at how successful it's been. And how good it is, and I think I'd be very keen for this to carry on as our first port of call to see these patients.
Thank you very much. Just while Dave Duffy, I'll just unmute him. There we go. Is thinking of an answer to his thoughts on ACL repair. If any of the physiotherapists who are watching have an answer for Mickey JHA, is there a video resource for online exercises for specific knee problems? If you could help us with that, or you may want to suggest that they come to see you. But I'm not aware of the best video resource for that. So Dave, what are your thoughts as you did the acute presentation on ACL repair if seen within 6 weeks?
The issue with ACL repair is, I mean, if somebody can crack it, it is, it's the ideal, but we're not there yet, in my opinion. We're far, far from there. The arguments that have been put forward in terms of doing it for the younger patients because you're not burning any bridges, I don't buy. The research that has been published, and it is sporadic, but what is out there shows that the re-rupture rate after an ACL repair in a young or skeletally immature, or somebody under the age of 18, is frighteningly high. So for that reason, I don't subscribe to it. The second argument that's put forward with you burning no bridges, well, I find that a difficult conversation to have with somebody who's in their teenage years that you've potentially operated on, then put through a period of rehabilitation which can take months and months and months, to have a high risk of failure. Because for that individual, losing not 1 but 2 seasons of sport, depending on, well, it could be devastating both on a personal level, but potentially, if it's an elite sportsman, career ending. So I don't think we're anywhere near the stage yet. Those that advocate it, the data seems to come out that it's better in the low activity older patient, but it's certainly not part of my treatment plan.
Yeah, I suspect you speak for all of us there. It's something that is worrying to us, unproven, and has gained a bit of traction, but we've seen some pretty worrying results. The only exception, obviously, would be that case that Dave showed of the bony avulsion, where that's effectively a repair, but it's a repair of the bone rather than the ACL ligament itself. John, you were going to, it says on my screen that you were going to answer a question live to Ivana about a patient continuing with sport but no swelling. Is that?
Yeah, we do see these, and as Jim mentioned, the key really is in the history. But I would have a very low index for getting an MRI scan for a player that has left the field of play, because they don't always get an effusion, they don't always get a hemarthrosis initially. and sometimes they can have meniscal tears with very little swelling. So in this day and age, I've got a very low threshold for MRI scanning these patients.
Thank you. And thank you to Charlotte for answering that question. I think that wraps up the questions. Oh, there's, yeah, so Fern's answering as well, which is helpful as well for the video question. Thank you for the feedback in the poll. That's pretty clear. The couple of individuals who didn't understand the question, maybe if they could contact us afterwards, and we'll get John to explain it. But that gives us a pretty clear direction and clearly a lot of work to do going forwards, which will be good. So thank you for that. Thank you also for the support from Nuffield Health in helping to set this up and get the information across to as many people as possible. And thank you all for listening tonight, and to my colleagues from the Yorkshire Knee Clinic for participating. Okay, thank you. Good night.
Thanks,